Hepatitis B, HBV. Hepatitis B is a double-shelled particle containing DNA. This particle is composed of the following. Number 1, HBcAg, hepatitis B core antigen, that is antigenic material in an inner core. Second, HBsAg, hepatitis B surface antigen, that is antigenic material in an outer coat. Third, HBeAg, an independent protein circulating in the blood. Each antigen elicits a specific antibody. Anti-HBc persists during the acute phase of illness, may indicate continuing hepatitis B virus in the liver. Anti-HBs detected during late convalescence usually indicates recovery and development of immunity. Anti-HBe usually signifies reduced infectiousness and significance. HBcAg found only in liver cells, not in serum. HBsAg usually detected transiently in blood of 80% to 90% of infected persons. May be noted in blood for months or years, indicating that the patient has acute or chronic hepatitis B or is a carrier. HBeAg, if absent, the patient is an asymptomatic carrier. If present, it indicates highly infectious period of acute active hepatitis. If it persists, indicates progression to chronic state. Mode of transmission is primarily through blood, percutaneous and permucosal route. Oral route through saliva or through breastfeeding. Sexual activity through blood, semen, saliva or vaginal secretions. Gay men are at risk. Incubation period is 2 to 5 months. Occurrence is for all ages but mostly affect young adults worldwide. Mortality can be as high as 10%, with another 10% of patients progressing to carrier status or developing chronic hepatitis. It is the main cause of cirrhosis and hepatocellular carcinoma worldwide. Clinical manifestations. Symptom onset usually more insidious and prolonged compared with HAV, that is hepatitis A. May be asymptomatic. 1 week to 2 months of prodromal symptoms: fatigue, anorexia, transient fever, abdominal discomfort, nausea and vomiting, headache. Extrahepatic manifestations may include myalgias, photophobia, arthritis, angioedema, urticaria, maculopapular eruptions, skin rashes, vasculitis. Jaundice in icteric phase may in rare cases progress to fulminant hepatic failure, also called fulminant hepatitis. May become chronic active or chronic persistent, that is asymptomatic hepatitis. Diagnostic evaluation: elevated serum transferase level, that is aspirate transaminase AST, alanine transaminase ALT for all forms of hepatitis. AST, ALT to be checked. Radioimmunoassays to include HBsAg, anti-HBc, anti-HBsAg detected in various stages of HBV. Anti-delta hepatitis for HBsAg and HDV, or the detection of IgM in acute disease, IgG in chronic disease. Liver biopsy to detect chronic active disease progression and response to theory. Management: rest according to patient's level of fatigue, therapeutic measures to control dyspeptic symptoms and malaise, hospitalization for protracted nausea and vomiting or life-threatening complications. Small frequent feedings of a high caloric, low fat diet Proteins are restricted when the liver cannot metabolize protein byproducts as demonstrated by symptoms. Vitamin K injected subcutaneously if prothrombin time is prolonged. Intravenous fluid and electrolyte replacement as indicated. Administration of antiemetic for nausea. After jaundice has cleared, gradual increase in physical activity. This may require many months. Complications: dehydration, hypokalemia, chronic carrier hepatitis or chronic active hepatitis, cholestatic hepatitis, fulminant hepatitis. Liver transplantation may be necessary. Thank you.